Types of wound healing and types of wounds and wound healing. This is a very crucial and a very important topic on discussion. And you realize that we have two types of wounds. We have the open wound and we have the closed wound. So on open wounds, you can classify them into incised wounds, lacerations, abrasions. You can have puncture wounds. You can have penetrating wounds and you can have degrading wounds. Now, on closed wounds, you can have physiological degloving wounds. When we say degloving, is when you remove the skin and the damage. Then you just leave on the subcutaneous tissue. So this is a picture of a wound, but it's a cut wound, it's an open wound. Then you can see other wounds here, they are so dirty, not clean wounds, they are not primary wounds, we want to see them. So how can you classify them? We have two types of wounds. We have the open wound and the closed wound. So you can classify the wounds as clean. Then you can say we have a clean contaminated. Then we have contaminated and we have the dirty wound. For the clean wounds, they have a percentage of up to 5% contamination or getting infected. But for the clean contaminated one, for the clean ones, they have about 2% to get infected. But clean contaminated, they can have up to 5%, then contaminated up to 15%, and then dirty ones can have up to 40% chance of infection. Then how do you evaluate the wounds when a patient comes to hospital? So you use the A, B, C, D. This is very important in end trauma patients. So you ensure hemostasis. You also remove obstruction and then you take history. Sometimes the history of the patient is very important. So the patient will tell you the symptoms, how he or she is feeling, the types of forces that are applied, and the contamination, then the events that were taking place. He'll tell you all these, whether they have allergies, they have medications that they are taking, whether they have comorbidities, some diseases such as hypertension, diabetes mellitus are going to impair wound healing, as we're going to see. See the tetanus status. And then when you are examining the wounds, just check on the location. Some locations are so they need dressing. Some locations don't need. For example, the injury of the tongue. You need to dress it. You need to check on the size. You need to check on the shape. Then you need to see on the margins, the depth, and then the alignment with the skin. Then you need to see the neurofunction. So you see the neurofunction, you see the function, you see the size, you see the shape, you see the margins, you see the depth, you see the location, and then the alignment. Then see the vascular function, the tendon function, the underlying structures, and the wound contractions, the foreign bodies which are present, which sometimes impair the healing of the wounds. So when you prepare the wound, the patient has just come and you need to prepare it so that you can examine so well to see whether there is more debris, where there is entry of other foreign external bodies. You need to anesthetize first the patient. Then you need to achieve hemostasis. Then you need to remove any foreign body, then irrigate properly and clean it with normal saline. Then debride. Debridement means to remove the dead tissues or those tissues that do not show signs of viability, then you use antibiotics. Then you can give tetanus prophylaxis. Then how do you close? You can have three types of closure. You can have primary closure, delayed primary closure, and secondary closure. So for primary closure, you're going to suture or use staples or adhesives or the tape. This one is performed on recently sustained lacerations, less than 12 hours, and generally, and perhaps for the face is 24 hours. That's very important to take into account. And then we have delayed primary closure. This is observed for 4 to 5 days, and then the wound is closed after you've done what we've said here. So you close it 4 to 5 days. This other one, you do it 12 hours, less than, generally speaking, but for the face, is less than 24 hours. And then secondary closure. These, you need to allow them to granulate. We're going to see what's a granulation tissue. And then after that, you need to close it. Then what's healing? Now we need to see the process of healing. So healing is complex and dynamic. It means restoration of cellular function and tissue layers. Is very key. It is very important. So categories of healing. We can heal by primary intention or delayed primary wound healing, and then we can have secondary healing. They're almost concomitant with what we've seen here of closure. So it's close to this. And then in secondary healing, as in secondary closure, there is inflammatory response that is so intense, is so massive, and then there might be massive wound contraction. So the sequence of events in wound healing, we have hemostasis. That's the first thing we were achieving even before during evaluation. Then we have inflammation, the response, natural response of the blood vessels and the cells is a cellular and a vascular response. And then we have proliferation, and then we have remodel. These are the most high things you need to take, the sequence of events in wound healing. So what about hemostasis? It's complex. It has vasoconstriction as the immediate step. And then we have platelet adhesion to the damaged endothelium. And then there's coagulation cascade. And then there's fibrinogen cleavage into fibrin, then forming a clot. Then we have fibrin that provides the structural support for cellular constituents of inflammation. So never forget, we have in hemostasis, it has its own components. We're going to see vasoconstriction, platelet plug formation, and then we have coagulation cascade, and then we have which forms the fibrin glow, and then finally we can have fibrinolysis, which is not here. So here we have the adenosine phosphate, and then we have the platelet-derived growth factors, the and then we have um, endothelial growth factor, and then these all are chemotactic, and then they have mitosis. We have transforming growth factor beta. We have platelet derived growth factor. Then all these are very, very high yield. What about inflammation? It's a complex stuff as well, as we've said. It involves the vascular system and also the cellular system. Within 6 to 8 hours, and it lasts almost 3 to 4 days. We have the polymorph nuclear cells, they engorge at the wound. The monocytes develop into tissue macrophages. And then we have the transforming growth factors, the cytokines and the interleukin 1, the tumor necrotic factor, and the platelet-derived growth factor. Multiplication of endothelial cells can result to angiogenesis. And then we have the third stage of proliferation. It begins on day 3 when inflammation has reached day 3. This one lasts for few hours. This one is hours to days, 6 to 8 hours, and then 3 to 4 days. This one begins day 3. It involves fibroplasia that is responsible for the initiation of the other stages, the matrix deposition, angiogenesis, and then reepithelialization. Don't forget this. Remember, we from the blood vessels, then there is matrix, there's fibroblasts. They come here. Then the epithelium reforms again. He healed. Then remodeling stage is that it takes and it can last many years. And then the balance between collagen degradation and deposition is achieved here. Collagen reorganizes along the lines of tension. Type 3 collagen is replaced by type 1 collagen until a type 1 to type 3 ratio is 4 to 1. This is on remodeling. Tension, collagen organization. We have replacement of collagen type 1 to type 3, type 3 to type 1, and it lasts for years. It's contraction of the wound. This maximal tensile strength of the wound that is achieved by the 12th week. The ultimate resultant scar has only 30% of the tensile strength of the original skin at 1 year. And even when we've completed healing, we only be able to achieve between 70 to 80% of the original strength of the tissue that was present. Then what is wound contraction therefore? Very high, because we've said contraction of the wound happens. So in remodeling, so this one we have myofibroblasts. The cells that are responsible on laying down the myofibrils with their myofilaments in the cytoplasm. They appear in day 3 to 21. They're located in the periphery. They pull the wound of the edges together, the edges of the wound together. Contraction across joints. It can cause a contracture. You can see here it's very nasty because the fibroblasts, the myofibril, they pull the wound, the edges of the wound together. And therefore, if it were around the joint, it's gonna form such a stuff. Then what are the factors that can affect wound healing? You can divide them into local and systemic. And the local, we have perfusion affected by cigarette smoking. You can speak about vascular diseases of the periphery. You can say irradiations, and then the foreign bodies, dressings, edema, infections around there. And then what about the systemic? You speak about steroids, diabetic mellitus, malnutrition. Then you speak about malignancy. Then the new developments in the wound care. Sometimes we've had um, new things that are engineered. Now we have bioengineered skin when you want to do a graft. We have negative pressure dressing. We have growth factors. Now we have also stem cell therapy. All these are very new developments that have come up, and all these are done to improve wound healing because these are the factors that influence and improve wound healing. Until the next lecture on vasoconstriction and hemostasis, Keep in touch, subscribe, and like, share to friends. Thank you.